Hi, my name is Dr. Zev Wainberg. I'm a professor of medicine and co-director of the GI Oncology program at UCLA School of Medicine in Los Angeles, California. So one of the controversies over many years has been what kind of surgery we should do in gastric cancer. And we know that lymph node spread of gastric cancer is the most fundamental risk factor for gastric cancer. So it gives us the prognostic information on whether or not a patient is at high risk or low risk based on lymph node involvement. Historically, in the outside of the United States, they've always been doing a D2 gastrectomy. A D2 gastrectomy involves taking out not just level 1 lymph nodes, but level 2 lymph nodes, which is a much more extensive lymph node dissection, in which there is a risk of obviously a more extensive surgery, and also, generally speaking, has been associated with a better prognosis. And this has been the subject of many, many studies over the last 30 years, which have both been done in Asia, which have reaffirmed the role of a D2 gastrectomy as being the standard of care. And even in Europe, a number of years ago, a large study was done, published, a 10-year follow-up was published from the Netherlands, which clearly did show that there was improvement in overall survival in the group of patients who received a D2 gastrectomy over a D1 gastrectomy. Now, a D2 gastrectomy will automatically include more than 50 nodes, which will have the advantage of having, number one, more accurate staging, and therefore also the premise has been reduces the risk of local regional recurrence, so that if you do indeed have a better debulking, let's call it, or removal of local regional lymph nodes, the risk of a subsequent local recurrence diminishes. And that's been one of the theoretical, and to some extent has been shown in the literature to be the advantage of a D2 gastrectomy. Now, depending on where the surgery is done, it's not always possible to have a D2 gastrectomy. It does require, in my opinion, to be done in a center where a suitable number of gastrectomies is being done, because there is a little operative risk added to it. But if it can be done, if it's going to be done in a large center, then almost certainly any gastric cancer surgeon will have sufficient experience doing D2 gastrectomies where that would be the goal of a surgery to do. Now, the question comes up about radiation often, and instead of doing a D2 gastrectomy, can we just do a D1 gastrectomy and then radiate the area as a approach to basically substitute for a more extensive surgery? And there has been studies that have looked at that, but a lot of the studies, in my view, did not specifically demonstrate that that can be a suitable alternative to a D2 gastrectomy. Now, in Asia, and they have pushed it even beyond that and have done often what's called D3 gastrectomies, which include removal of para-aortic lymph nodes and even further extensive lymphadenopathies, and to the spleen and beyond. And there's been no consistent evidence in the Western world that a D3 gastrectomy adds benefit to a D2 gastrectomy, so that's certainly not recommended at this time. But because of a survival advantage shown in the Western world study, a D2 gastrectomy with at least 15 lymph nodes removed should be the target that we should achieve for our patients, because it both provides accurate staging information and most likely some prognostic, which includes prognostic value, and most likely also some fundamental therapeutic benefit by removing a majority of the risk of local recurrence.